Dear members of RCAAB, I welcome you all to our first training and professional development event. I'm Dr. Shamshad Khan, one of the members of RCAAB who has been with RCAAB since the very beginning. And I would conduct today's session. And our first session would be on advanced life support for in-hospital adult cardiac arrest. So this is a topic which everyone should be familiar with. And I guess by this time, all of our postgraduate doctors have had the chance to participate in some form of providing either basic life support or advanced life support in their hospital setting. Yeah. So if we go into the topic a little bit more, what the objectives of this session are. So we're first going to discuss the importance of knowing ALS. Then we'll go through the 2015 UK and European Resuscitation Council ALS guidelines. We'll have gain the knowledge to perform ALS correctly and understand specific treatment options to manage some of the reversible causes. Okay. Then, if we are able to get a spontaneous return of circulation, then we'll go to post-resuscitation care. So we'll go to the ALS algorithm first. Yeah. Cardiac arrest is a life-threatening state of circulatory failure, which is secondary to the loss of cardiac systolic function. That means the heart is not contracting. Yeah, the heart has come to a standstill and all activities of life are stopping along with it. So when the heart has stopped, what do we need to do? We need to restart the heart. Yeah, the basic function of the heart, it's a pump. It pumps blood throughout the body to the brain, to the other essential organs, and continues life. So whenever the heart stops, we start CPR, we start pumping, and we do it from the outside. Yeah. So advanced life support and basic life support are both there to facilitate this circulation. Okay. So basic life support focuses on just basic airway management and CPR, whereas advanced life support has a few more additional things, such as rhythm recognition, continuous CPR, airway management, treating the reversible causes of cardiac arrest. Yeah. So at the heart of both ALS and BLS, we need to have early recognition, early CPR, and early defibrillation if appropriate. So early defibrillation in case of shockable rhythms, okay, which we are going to discuss later on. And these are the most important aspects that would save a person's life. The main difference between ALS and BLS is that ALS involves invasive procedures like advanced airway techniques, administration of some drugs to treat, and addressing the underlying cause of the arrest. Okay, so today's UK guidelines are closely following the European guidelines, and they have both come to existence from 2015. Okay, now we are going to see a summarized diagram. This is our main diagram, which we follow the algorithm for ALS. I'm not going to go through the algorithm now, but I can come back later on after we've discussed everything, just to show that this one poster summarizes what everyone needs to know and do in case of a cardiac arrest. Yeah. We start from the initial assessment of a collapsed patient. Suppose there's a nurse in the hospital who's called you to see a sick patient. You go there. What do you do first? Number one point is to ensure personal safety. Yeah. If you need to first check if the patient is in a safe environment, put on non-sterile gloves as soon as possible. Yeah. Put on other personal protective equipment wherever necessary. Because if a patient has a very contagious disease, you won't go jumping in before protecting yourself. Yeah? Okay. First of all, ensure personal safety. Next is to check response. What do we do to check response? We go to the patient, we gently shake the patient's shoulders and ask very loudly, "Are you all right? Apni thik achen? Amar kotha shunte pacchen?" Very loudly. The patient might be drowsy or anything, and check if the patient gives a response. Yeah. If there is no response, ask one of the other team members to give out a crash call. So hopefully there should be a CPR team or a cardiac arrest team available in the hospital who, as soon as the crash call comes to the scenario. And before the cardiac arrest team comes in, it's the first responder's duty to continue basic life support and transition into advanced life support when equipments are available. Okay. So we check for response, then we go into assessment. What do we do in assessment? We do three things. We look, listen, and feel. Yeah. Look, listen, and feel. What do we look for? We look for chest movements, listen for breath sounds, and feel for expired air on our cheeks. Yeah. And all of this should be done in 10 seconds time, not more than that. Okay. And before we do the look, listen, and feel, we just gently lie the patient on their back, open their airway, usually with a head tilt and chin lift movement, provided there is no cervical spine injury. I've discussed later on what we need to do during a cervical spine injury. Yeah. Then an important part here for look, listen, and feel. If the patient has agonal breathing, which is irregular gasping breaths, it should not be mistaken for any normal breaths. That's why the algorithm says unresponsive, either the patient is unresponsive and not breathing normally, because the patient might be gasping, but that's not a normal breath and the patient is already in cardiac arrest. Yeah. While we assess for breathing, simultaneously, we can also assess for the carotid pulse. And it should be no longer than 10 seconds. So not to waste time, you just need 10 seconds to look, listen, and feel, check for the pulse. What do we do then? A member of the team calls the cardiac arrest team. Whoever's there, the nurse might be there, or another junior doctor might be there, who can just go and put out the crash call for the cardiac arrest team to come over. Yeah. And at that time, the first responder immediately commences CPR. Yeah. In a ratio of 30 chest compressions followed by 2 ventilations. Usually in UK, every ward has their own resuscitation trolley. So 30 chest compressions followed by 2 ventilations. The resuscitation trolley contains everything that is necessary to support the patient during that time, starting from airway kits, airway adjuncts, the ambu bag, drugs, IV access, and everything. Okay, and also the defibrillator. The defibrillator is already present in the ward. What we need to do is just attach the defibrillator while we are giving chest compressions. We do not interrupt chest compressions to attach the defibrillator. Okay. So once the defibrillator is attached, the next thing is to do is a rhythm check to see if a patient has a shockable or a non-shockable rhythm. This will determine the next step in the ALS algorithm. Either it's a shockable or a non-shockable rhythm. So, ALS for shockable rhythms. What are the shockable rhythms? If the patient has either ventricular fibrillation or pulseless ventricular tachycardia. These two are shockable rhythms and can potentially be treated by using a defibrillator. Yeah. Therefore, these patients require a shock. So we can see here, this is the ECG trace or ventricular fibrillation. The complexes are broad, irregular, with varying QRS complex waves. Yeah. Then there's pulseless ventricular tachycardia. So there can be a ventricular tachycardia with a pulse where the patient has not arrested. But if the patient does not have a pulse and the monitor shows a regular, broad, wide complex tachycardia, then it's a pulseless ventricular tachycardia. That patient is in cardiac arrest, needs CPR, needs shock as soon as the rhythm is recognized after the defibrillator is attached. So first of all, now I'll go to the shockable rhythm management. What do? We go back. As soon as we confirm the cardiac arrest, we call the resuscitation team. Yeah. We commence the CPR in a ratio of 30:2. We turn on the defibrillator and apply the pads to the chest. As soon as the pads are applied, we pause for 5 seconds just to assess the rhythm. While assessing the rhythm, we also put our hand on the carotid to see if there's a pulse. Because by this time when the patient has had CPR, some of the patients might already get a spontaneous return of circulation. Okay, then there's ventricular fibrillation or pulseless ventricular tachycardia. That's one of the things if we find it in the monitor. So if it's a ventricular fibrillation or a pulseless ventricular tachycardia, we immediately resume chest compressions. While we resume chest compressions, another person who's in charge of the defibrillator charges the defibrillator. When the defibrillator is fully charged, everyone gets back from the bed. The person who's continuing chest compressions is the last one to get off the chest. So whoever is operating the defibrillator gives an instruction for everyone to clear out, then to stop compressions. Yeah. And another important thing that we're going to discuss later on is the oxygen. The oxygen should be away from the patient while we are giving the shock. Okay. As soon as the shock is delivered, then as soon as everyone's away from the patient, the shock is delivered, and immediately we resume CPR for 2 minutes before checking for another rhythm. Okay. So we start chest compressions, pause CPR to assess a rhythm, see if the patient has a VF or a pulseless ventricular tachycardia. If the patient has a VF or a pulseless ventricular tachycardia, that is one of the shockable rhythms. We go into chest compressions again, We charge the defibrillator. Once the defibrillator is charged, everyone else gets away from the patient. Last person to get away is the one who is doing chest compressions. As soon as he gets away, the person on the defibrillator gives a warning and then delivers the shock. As soon as the shock is delivered, we resume CPR. We resume CPR, and that is for 2 minutes. After 2 minutes is over, then we pause again for 5 seconds just to do a rhythm check. So when we pause, we might find two things. Either there is return of spontaneous circulation, or the patient might go into PEA or asystole. Then the algorithm changes to the non-shockable rhythm one, or the patient is still in ventricular fibrillation or pulseless ventricular tachycardia, and we continue on with the shockable algorithm. Again, we start chest compressions, we charge the defibrillator, we stop the chest compressions and deliver the shock, we resume CPR. Okay. On to the next slide. So if it's a monitored or witnessed cardiac arrest, I've already discussed these things. If it's a shockable VF or a pulseless VT, in a monitored setting, it could be in the CCU, it could be in the ICU, where the monitor was already attached. We see that the patient has gone into VF or a pulseless VT. We have the defibrillator nearby. We just attach the defibrillators. Yeah. And we give the patient 3 quick successive shocks. These are known as stacked shocks, which might return the patient's spontaneous circulation. And these 3 shocks should be only counted as one if there is no return of spontaneous circulation. And we start CPR for 2 minutes and go into the shockable rhythm algorithm. Okay. So we've had a slight interruption in between our session. No problem. I was talking about giving the patient 3 quick successive shocks if the patient has had a shockable rhythm identified, and we count these as 1 shock because these 3 stacked shocks are the first shocks to get the patient back into spontaneous circulation after we've identified ventricular fibrillation or a pulseless VT. Yeah. So, and I've also said if a defibrillator is not readily available, we can use a precordial thump while awaiting the defibrillator's arrival. It can get patients back into a spontaneous circulation, but that is rare. But if the defibrillator is not there, just give it a go. Give a big precordial thump with lots of energy. It might get your patient back into spontaneous circulation. But if the defibrillator is there, always use the defibrillator. Okay. ALS for non-shockable rhythms. There are 2 types of non-shockable rhythms, which are pulseless electrical activity and asystole. And these do not respond to defibrillation because there is nothing to defibrillate. There is no rhythm. And these patients benefit from ongoing CPR, and that has a chance of getting the patient back into spontaneous circulation. One very important thing is most commonly pulseless electrical activities are associated with a reversible cause. So if pulseless electrical activity is present, we go through the 4 H's and 4 T's of reversible causes. I've covered this later on, so we'll go to them, no problem. We can see a rhythm which looks like a sinus rhythm, but you won't feel a pulse. That means the patients in pulseless electrical activity should resume on CPR immediately. No need for any defibrillation. Then here we can see asystole, yeah, which means the heart has ceased all mechanical activities, and the patient will again benefit from chest compressions. So we'll go to the summary of the non-shockable rhythm management. We confirm cardiac arrest. As soon as the cardiac arrest is confirmed, the immediate responder commences CPR. Ask one of the team members to give out a call to the resuscitation team, a crash call. As soon as the CPR is commenced, one of the other team members should get the defibrillator, attach the pads on the chest. As soon as the pads are attached, we just pause the CPR and assess the rhythm for maximum 5 seconds. As soon as the rhythm is assessed, if we see that the patient has a non-shockable rhythm, we immediately go for CPR again for 2 minutes. During this 2 minutes, what we can do is we can try and insert an advanced airway, secure an intravenous access, and consider the reversible causes. After 2 minutes of CPR, we pause again and assess the rhythm for 5 seconds. There might be 3 things. Either the patient might still have a non-shockable rhythm, go into a shockable rhythm, or the patient might have a return of spontaneous circulation. So if the patient goes back into a shockable rhythm, we go back to the shockable rhythm and follow that pathway. If the patient's in PE or asystole, we still continue to follow the non-shockable algorithm. And for patients in PEA or asystole, this is one of the most important things, is if a patient has PEA or asystole, we give them 1 milligram of adrenaline as soon as we identify that the patient is in a non-shockable rhythm. And this is repeated every 3 to 5 minutes during the ALS protocol procedure. Then a little bit about chest compressions, 30 times at a rate of 100 to 120 beats per minute with a depth of 2.5 to 6 centimeters. That is pretty hard. And we have devices here to show when we are doing CPR on a mannequin if our chest compressions are adequate. And one of the most interesting things is we do go down deep, but we do not let the chest recoil enough. We do not let the chest recoil enough and go back to its original size. So we just keep going down and down. The heart does not get a chance to fill up with blood so that it can push it forward again. So always remember to come back up the full length for the chest to recoil completely. Never attempt to pause chest compressions for less than 5 seconds. As soon as we have a airway in, it could be tracheal intubation or a supraglottic airway, we start asynchronous ventilation. So asynchronous ventilation is the persons who are doing CPR chest compressions continues to do chest compressions, and the person who is ventilating a patient ventilates in a physiological rate, maybe like 16 breaths per minute. The easy thing to do is like calculate 1, 2, 3, 4, give a breath to the patient, then again say 1, 2, 3, 4, give another breath to the patient. That way you'll see that you're maintaining the breath at 16 breaths per minute. Otherwise you might hyperventilate the patient because you have the ambio on your hand and it's very easy to get distracted. Okay. Chest compressions alone will not typically restart the heart, yeah, but it can restore up to 30%. That's why we need airway support as well. Now to discuss a little bit about defibrillation. It is the cornerstone of treatment for pulseless VT and ventricular fibrillation. Yeah. If there is a delay of 5 to 10 seconds in providing the shock, it is enough to reduce the chances of the shock being successful. So early defibrillation is one of the things that is recommended in the 2015 UK and European Resus Council guidelines. The current guidelines recommend that at least an energy of 150 joules for the first shock from a biphasic waveform defibrillator. Most of them are biphasic waveform now. But however, the shock energy selected should be based on the defibrillator's manufacturer's guidelines. If someone is unsure and does not have the guideline and the machine is not labeled, which at most times are not labeled, we use the highest available energy. Do not think giving more energy will kill the patient. The patient's already dead. Giving more energy might revive the patient. So following the first shock, yeah, we either have a fixed or escalating energy strategy for defibrillation. If the initial shock is unsuccessful, then we use higher energy for the second and the subsequent shocks. And again, to emphasize the importance, once a shock has been delivered, chest compressions should immediately be restarted. A very important point for oxygen during defibrillation, the ambu bag, which we're using to give oxygen to the patient, should be removed away from the patients before we give the shock. It should be nowhere near or on the bed. Yeah, because the patient might catch fire and the physician who's doing the airway is at risk as well. Now we come to the airway management. When I was very young and I used to do CPR, I used to just concentrate or think about one thing only. Has the patient got the airway? Has the patient got the airway? And by airway, only one thing I used to think about was tracheal intubation. So now we'll see that tracheal intubation is not the most important thing during an ALS provision. So airway management is necessary to maintain oxygenation. In advanced life support, the focus is often placed on securing an advanced airway, but this principle has been challenged in a number of recent observational studies, which has shown that delaying other things to provide a secure airway actually results in worse patient outcome. So the UK and the European resuscitation guidelines now advocate a stepwise approach to airway management. Starting from basic airway management, which is simply the head tilt, chin lift, or jaw thrust. It is an easy thing to do, but needs a little bit of practice. Anesthetists do it every day before they put the patient under anesthesia. So a good person to teach the basic airway management and the advanced airway management are anesthetists or intensivists. Okay. And this should be in combination with a pocket mask or a bag valve mask. The bag valve mask is the ambu bag that we all know. If the patient has a suspected cervical spine injury, we at first use only the jaw thrust or chin lift. in combination with manual inline stabilization. That means an assistant stabilizes the neck and the person on the airway just does a jaw thrust and a chin lift. But if the airway is still obstructed, we do head tilts in very small increments until the airway is open. As soon as the airway is open, we keep on doing manual inline stabilization of the head and keeping the airway open and providing the patient airway support. Suction can be necessary because patients might be vomiting, aspirating. So suction is very necessary to get those things away so that it does not go into the lung. If it goes and the patient aspirates, it causes another hazard and decreases patient survival rate. Yeah. Let's see some of the airway adjuncts which we are all familiar with. This is the oropharyngeal airway. It usually moves the tongue away from the posterior pharynx so that you have a proper passage of air. Then there's the nasopharyngeal airway. Both of these are very easy to use and should be in the resuscitation trolley for you to make use of it as soon as we start ALS. Then there's some advanced airway. This is the ambu bag. This is a laryngeal mask airway. This is a slightly modified version of a laryngeal mask airway, which is called the iGel. These two things are very easy to use, and this is the easiest of them all. And this is our traditional endotracheal tube. Needs expertise and expert hand to put in. But using an iGel is very easy, and now the UK hospitals are providing iGels in the resuscitation trolley because you can get a secure airway very easily, which is sufficient during the first phase of the advanced life support treatment. Tracheal intubation has many benefits. We can give asynchronous ventilation, effective ventilation in patients with poor chest compliance. There will be minimal gastric inflation because the tube is in the trachea, and we can protect the patient from aspiration because the trachea will be sealed off. Any vomitus that comes out won't go into the lungs. But there are some disadvantages as well. There's a risk of misplacement. It can go into the esophagus, and that happens usually if there's someone who's not expert enough trying to intubate. There is interruption to chest compressions, which I've seen many times if someone is too much focused on getting the airway. There's a high failure rate of insertion during chest compressions because the patient's moving, the body is not stable. It requires a highly trained clinician, and it also requires a waveform capnography, which shows the end-tidal carbon dioxide output to see if it's actually in place. Okay. But all these benefits that we can see, asynchronous ventilation, effective ventilation in patients with poor chest compliance, these can be achieved with the iGel as well. And for aspiration, the iGels have a side port where we can put a suction tube to aspirate the gastric contents. So this is the iGel, and many of the ALS courses now provide training just to how insert the iGel. And it is very easy if a person has inserted 1 or 2 iGels. And there's no further need for training, and he can insert iGels in arrested patients very easily. Then there's cricothyroidotomy. If the patient definitely has no airway, yeah, because of a foreign body, facial trauma, or laryngeal edema, then a surgical airway may be life-saving, but it needs training, specialized. It's a specialized procedure. It is very easy. If a person is trained, they can just stick a needle in the cricothyroid membrane and the patient at least can get an airway, or we can put a surgical cricothyroidectomy if the patient does not get a sufficient airway after the needle. Now we go to the reversible causes, the 4 H's and 4 T's. 4 H's are hypoxia, hypovolemia, hypokalemia or hyperkalemia, hypothermia or hyperthermia. So if things to keep in mind while doing CPR, the team leader will go through these 4 reversible causes. Is the patient getting oxygen? Do we have a secure airway? Are we giving the patient enough oxygen? Yes. Okay. Hypoxia is covered. Do we have an IV access? Is the patient getting any fluids? If the patient is getting fluids, then hypovolemia is covered. If the patient is getting fluids, then we need to check if the patient has had hypokalemia or hyperkalemia, which can be reversible causes. We can give the patient potassium or give the patient calcium gluconate if the patient has hyperkalemia, which can reverse the patient. And then there is hypothermia or hyperthermia. Those two can be treated as well. Hypothermia can be treated by warming the patient. We usually use bear huggers here. It's a plastic wrap sort of thing, a plastic wrap sort of thing, but it has hot air flowing through and it gets the patient's temperature up. Yeah, and for hyperthermia, we can use cooling methods, just saline bags that are kept in the deep freeze, which are in the freezer, which are cold. Just put them under the patient's elbows and in the groin area and other places, and the patient's hyperthermia can be tackled as well. Okay, to see if the patient has hypokalemia or hyperkalemia, one thing we need to do is we need to get an ABG from the patient and send it off. If an ABG is not possible, a VBG is sufficient enough. Just stick the needle in the patient's groin, get the blood out from the femoral artery or the femoral vein. Doesn't matter. It will show you if the patient has a hypokalemia or a hyperkalemia. Then there are the 4 T's, which are thrombosis, a tension pneumothorax, a tamponade, or toxins. For thrombosis, we are already seeing the rhythm. We think if the patient has had a myocardial infarction, that is one type of thrombosis. The patient needs to go to a cath lab and the thrombus aspirated, a primary PCI done, or to think if the patient has had a pulmonary embolism. Things that can indicate the patient has had a pulmonary embolism is the patient might have a DVT in the leg. So if one of the legs are swollen, or it's a post-operative patient or a patient with cancer who's bedridden, those patients can easily get a pulmonary embolism. Or any patient who has had significantly less mobility than in the last 3 days can get a DVT and subsequently a pulmonary embolism. So always keep in mind thrombosis. Then there's tension pneumothorax. While we're doing CPRs, while we're doing rhythm checks in the 5 seconds, we do listen to the lungs. If you see that the trachea is deviated, and there is silent chest in one side and the air is going inside the other, then the patient has a tension pneumothorax. The tension pneumothorax should be treated with it. Either you can just put a needle in if nothing is there, a wide bore needle, or if you have the apparatus, you can put a chest drain in, and that will treat the tension pneumothorax, and patient will reverse if the patient is lucky enough. Then there's tamponade. Yeah. If you have a cardiac ultrasound available, or if the patient is on any kind of blood thinners or has had a central chest trauma, you should think about tamponade. Or even if the patient was admitted with a massive anterior MI, he could have had a ventricular free wall rupture and developed a tamponade. And as soon as you aspirate the tamponade, the patient will regain circulation. Then there are toxins. What kind of toxin? The patient could have ingested certain poisons, or the patient can have certain medications on their prescription chart, or could be taking certain medications which has lead to their cardiac arrest. For example, if a patient is taking ACE inhibitors for his heart failure and also taking spironolactone, the patient can get hyperkalemia, and it will be more in case of a patient who has a CKD. So these are toxins that you can think about, which will lead you to think about certain reversible conditions. Okay. Routine drugs during ALS. While I was back in Bangladesh, many years ago, when I was just an intern, I used to see whenever a patient goes into arrest, we use atropine, 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 and atropine again. But atropine has no role in advanced life support whatsoever. It is a rate controlling drug. I mean, it increases the heart rate, but it does not get you a heart rate. Yeah. So the drugs that we should use are adrenaline and amiodarone, but benefits during resuscitation, even with these drugs, remain unclear. There's no evidence that these drugs work, but we use these because these might work, and atropine does not work. Hold off the atropine if the patient is in cardiac arrest and is getting CPR. It's unnecessary. For adrenaline, it is the vasopressor of choice. A dose of 1 milligram of adrenaline is used, which is usually diluted in 10 mils, a 1:10,000 dilution. It should be given either intravenously or intraosseously if IV access is not possible. It is given as bolus, followed by 20 mils of normal saline flush. In a non-shockable rhythm, we should give it as soon as possible. In a shockable rhythm, adrenaline is given after 3 initial shocks have been delivered. Once adrenaline has been administered, we should continue to give it every 3 to 5 minutes during the resuscitation attempt, which usually equates to once every 2 cycles of CPR. So after every 2 cycles, we will give 1 milligram of adrenaline. And it is regardless of whether we are on the shockable or the non-shockable rhythm. Then there is amiodarone. The UK and European Resuscitation Council recommends its use in the shockable rhythms, that is either in VT or VF. And a dose of 300 milligrams of amiodarone diluted in 5% glucose, 20 mils, is given. Here we have resuscitation trolleys with pre-filled syringes. We can just give it, yeah, followed by a bolus of 20 mils of normal saline. The amiodarone is usually given after 3 defibrillation attempts, even if they were not consecutive. A further dose of 150 milligrams of amiodarone can be given after the 5th defibrillation attempt. If amiodarone is contraindicated in that patient, like if the patient has any previous drug allergies to it, then lidocaine can be another alternative. Blood sampling, performing blood tests during CPR for rapid analysis, like a via blood gas analyzer, which I said we can do an ABG or a VBG. Whichever we can get is enough. Then there is waveform capnography to see the end-tidal CO2. We can use it to see if the CPR is effective enough. If the CPR is effective enough, ventilation is effective enough, the end-tidal CO2 should reach a certain limit. And as soon as the patient has an airway in, it can be a tracheal intubation or even an IGEL, we can do waveform capnography with it. So here we can see a waveform capnograph. This is usually seen in the monitor. So this is while the patient is getting the airway. Yeah, but the CPR is of poor quality. That means chest compressions are not effective enough. The heart is not constricting enough and the heart is not recoiling enough to get enough blood and put out the oxygen throughout the body, because the carbon dioxide will come out of the mouth, come out of the lungs, and this is going to show that the patient has effective CPR. When there's a good quality CPR, we can see that the waveform capnography is in a certain limit. Yeah. With continued CPR, we'll see that there's a rise in the end-tidal carbon dioxide output, and it will indicate that the patient is heading towards a return of spontaneous circulation. Yeah. Then we can have peri-arrest ultrasound. If an ultrasound machine is available, you can just see and check if the patient still has cardiac activity. If there is no cardiac motion, it is highly predictive of death. Yeah, it's very intuitive. If your heart's not pumping, you're dead. And it should be done within 10 seconds. So a person should be skilled enough to try and attempt to use it. Then if we have a return of spontaneous circulation, we go back to the basics, the very basics, to increase the patient's survival. Yeah. If we have a return of spontaneous circulation and stop there, the patient might go into post-cardiac arrest syndrome, and the patient can have brain injury, myocardial dysfunction, systemic ischemia, and reperfusion injury subsequent to the arrest, as well as the initial precipitating pathology. That's why you need to do an ABCDE approach. What it is checking the airway again, assessing the breathing, like listening to the chest, checking if the patient's taking enough breaths in a minute, checking the saturation. Then for C is circulation, heart rate, blood pressure, pulse. Disability is the GC of the patient, temperature, pupils, if they're equal and reactive. Then exposure is to expose the patient and see if the patient has any other thing going on. Did the patient have any trauma? Does the patient actually have a DVT which has led to everything? Or is the patient bleeding out? Because one of my scenarios when I did my ALS training, in my exam scenario, it was that my patient was having a huge melena, and we needed to start the patient on a massive transfusion protocol while we were doing the CPR. Okay, so if the ABCD is good, the chances of survival to discharge goes over 50% in a patient with return of spontaneous circulation. Then there's post-resuscitation care. Saturation should be 94 to 98%. If the patient does not is not able to protect his own airway, he needs an advanced airway, waveform capnography. Then for circulation, obtain a 12-lead ECG, get a reliable intravenous access. Nowadays, we are moving away from the intravenous access in UK and EU. We are focusing on getting an intraosseous access as soon as possible, because it gives the width of a large green cannula, and you're able to push in fluids very effectively, push in drugs through it. And it can stay in up to 72 hours. Then to control temperature, a temperature should be around 32 to 36. We can use sedation to control this shivering. Look for a likely cardiac cause. If it's yes, in the 12-lead ECG, did the patient have a ST elevation? If yes, the patient goes for a PCI. If no, still consider a coronary angiography plus minus PCI. Yeah. If the cause for the cardiac arrest is identified, admit to the ICU after the PCI. If there's no cause identified, do a CT brain and or a CT pulmonary angiogram to see if the patient has had a hemorrhagic stroke or a patient has got a pulmonary embolism, which we need to treat. Yeah. So if there's no cardiac cause, go for the CT brain and the CTPA. If there's a cardiac cause, go through the cardiac cause algorithm. If we find a cause, treat it, put the patient in ITU. If there's no cardiac cause, do a CT brain and the CTPA. In ITU, they should have their own protocols of managing the patient, stabilizing the patient, allowing hypothermia to happen. Then, at last, we come to the decision of stopping a CPR. When is it okay to stop the CPR? First of all, we stop the CPR if the patient has got a return of spontaneous circulation. No need to do any more CPR. But if we are not achieving a return of spontaneous circulation, the team leader has to think about stopping the CPR and asks the other team members' opinion that we have gone through this, this, and this, but it is very unlikely because of this, this, and this that the patient is going to get a return of spontaneous circulation, and we should hold the CPR. And the European and UK Resus Council state in their guidance that asystole for more than 20 minutes in the absence of a reversible cause and despite ongoing advanced life support constitutes a reasonable ground for stopping CPR. But as long as the patient remains in ventricular fibrillation or pulseless VT, or if there is a potentially reversible cause, it is usually considered worthwhile continuing resuscitation. And yes, we have continued resuscitation like for 40 minutes, 50 minutes, and have got the patient back. The EU Resuscitation Council also recommends that we should consider terminating CPR if there is if the safety of the healthcare team is compromised, like if there's a fire or anything, stop the CPR, save yourselves first. The injury or disease has clearly led to irreversible death, stop the CPR. If the clinical team has become aware of a valid and relevant advance directive, like if the patient has said that I do not wish to be resuscitated, even if you had started CPR, you should immediately stop the CPR. Otherwise, if the patient gets a return of spontaneous circulation after that, you might get very bad legal implications because the patient didn't want it. It will be commensurate to battery, and you will be held responsible in the court of law. there is strong evidence that continuing CPR would not be in the patient's best interest. Like if a patient is very debilitated, is aged 85 or 90, has no quality of life, like cannot walk, cannot do his own things, it is usually in their best interest that you do not continue CPR. Because even if you achieve a spontaneous circulation, it would not give a patient a better quality of life. It would only increase the patient's suffering. So just one more time, I would go through the whole algorithm. Yep. See, someone's worried about a patient, we go see an unresponsive patient, ask the patient, are you okay? Are you all right? Can you hear me? Can you respond? That's for 10 seconds. That's for only a few seconds. You ask the nurse to call the resuscitation team. You look, listen, and feel. Look for chest movements, listen for breath sounds, feel for respiration or breath on your cheeks. And that has to be done within 10 seconds. Start CPR immediately, attach the defibrillator, assess the rhythm. If the patient is in a shockable rhythm, go to the shockable rhythm algorithm. If the patient is in a non-shockable rhythm, go to the non-shockable rhythm algorithm. For shockable rhythm algorithms, we deliver the shock as soon as we identify the shockable rhythm and immediately resume CPR and assess the rhythm after 2 minutes of CPR. In non-shockable rhythm, we immediately start CPR. We continue CPR, give the patient 1 milligram of adrenaline, do a rhythm assessment after 2 minutes, then again, assess the rhythm. And when the patient has a return of spontaneous circulation, we go through the ABCDEs, maintain their SATs, aim for a normal partial pressure of carbon dioxide in the capnograph, obtain a 12-lead ECG, treat the precipitating cause, think about cardiac cause. If there's no cardiac cause, we do a CT brain and a CTPA. If there is a cardiac cause, we obtain the 12-lead. If there's a cardiac cause in the 12-lead ECG, we send the patient to the cath lab. But if there's nothing in the 12-lead ECG, but still we are suspecting there could be a cardiac cause, we send the patient to the cath lab for a PCI. And then when it's treated, the patient goes to the ITU. Okay. We've gone through the whole algorithm once again. So yeah, last thing is you guys can turn back on your microphone, and if you have any questions, you can ask me.
Thank you, Dr. Shamshad, for your nice presentation. We are very happy having you here, really, though we have some interruption of our transmission. But your very nice voice, and we heard very loudly and clearly. We hope that we can continue this in future, and our RCAAB will be very happy having you really in time. And really, we are very excited, and definitely we have some questions in our mind. I think Dr. Zubair can contact the further.
Thank you for the very nice comments. Yes, Dr. Zubair, please.
My first question is, so we can start CPR. Can we start CPR without any cardiac monitoring?
Yes, you should start CPR without any cardiac monitoring as soon as you identify that the patient is in cardiac arrest. Just start CPR, then tell the nurse, can you please get help? Can you please call the others?
Okay. So, and in case of cardiac monitoring, actually, I found that there are 3 indications for that is the defibrillation, like pulseless VT and the ventricular fibrillation. We have already known that. And the asystole is also another indication for defibrillation.
No, asystole is not an indication for defibrillation. That concept is wrong. Asystole would not be reversed with defibrillation. It is usually shown, I mean, the general public has a little bit of concept that a heart can be restarted by giving a shock, but it is not restarted by giving a shock. It is only if the patient has a shockable rhythm, the patient will gain benefit from a defibrillation. So it's
So in
only two, it's pulseless VT and ventricular fibrillation.
and in that case, we can only continue the CPR.
Yes, in case of asystole or pulseless electrical activity, we can only continue CPR and give the patient 1 milligram of adrenaline. And
what?
continue to give 1 milligram of adrenaline.
Okay. So and what if we don't have any ambu bag in our hand?
If you don't have an ambu bag, a person can do two things. If it's a novice, maybe the nurse or the junior doctor who does not know how to do ALS, he can continue to do chest compression only till there is help arriving, because that chest compression will give at least 30% of the circulation, yeah, which will be enough to salvage the brain. I mean, keep the brain alive for a short period of time till help is arriving. But if a person is a little bit more advanced, has a pocket mask, they can use it to give 2 rescue breaths in between. And an ambu bag is very cheap and should at least be placed in all the wards.
Okay. And what is that pocket mask? I am not familiar with that thing. So is it for that is the replacement of mouth-to-mouth breathing?
Yes, that is a replacement for mouth-to-mouth breathing, because you have to. One point I emphasized over and over is the physician needs to protect himself. We do not want bodily fluid exchange between the physician and the ALS provider and the patient. Yeah, I'll show you a pocket mask.
Oh, okay.
And how can you show really with your picture?
Yeah.
Image.
That's good.
Google. Like pocket mask.
If you want, you can show it on your video. Can you show a live one? Live means in a video?
No, I don't have a live pocket mask with me right now.
Live
it is available in all the wards where there is no ambu bag. Yeah, very cheap. You can just keep it in your pocket. It's like a small wallet while you're in the hospital. Or if you don't have an ambu, you can just keep that. So it prevents bodily fluid exchange with the patients. Yeah, and protects the physician.
Okay. And what about the laryngeal mask airway and the I'm not familiar with that thing as well. Laryngeal mask airway.
In UK and EU, we are not focused on intubating the patients. Yeah.
Is it? Okay.
This is a laryngeal mask airway. It has a deflatable cup. Yeah. It simply goes into the patient's mouth. It is a very easy procedure. It sits on top of the larynx and does not allow esophageal contents to go in while we're giving breaths to the patient. Yeah.
But we need some hands-on training.
Yeah. And laryngeal mask airway and IGL training is very easy, and it does not need as much expertise to do like an endotracheal intubation. And every physician, any physician, even the novice physician or even the nurses can insert an LMA if properly trained.
Okay, I will go through some YouTube video if I can find it useful. And can you explain that jaw thrust? I'm not actually, it is not clear to me. Jaw thrust, how does it look like?
Jaw thrust, yeah, I can show that to you as well in YouTube. So head tilt, chin lift. We know these two, right? Jaw thrust is you put your fingers at the angle of the mandible and push it upwards. Yeah. When you push it upwards, it gets your tongue away from the pharynx.
I think a video will be sufficient.
Yes, but okay, and it is
We are waiting for the video.
Yeah, I'm also waiting for it to connect now.
Are you in your home or outside?
I'm in my home. Can you see the video?
Yeah, please. Thank you.
Sound? No sound?
We cannot hear the video sound, I think. Can you narrate, please, Dr. Shamshad, the video?
Yeah, so this physician is just going to show you how to insert the laryngeal mask airway. We can see that he has an LMA here. There's an ambu bag here, and there's a 50 ml syringe to put in some air to deflate the laryngeal mask airway. Yeah, so this is the laryngeal mask airway. This is the tube portion, and this is the supraglottic portion, which stays on top of the pharynx. Yeah, and there's a midline indicator to show that you stay in the midline while inserting it. It is usually inserted in a swift pen-like motion. Before inserting it, we take the air out of the laryngeal mask, deflate the cuff, use a little bit of gel on the laryngeal mask, yeah, to make it smooth enough to go in. To insert the LMA, you hold the LMA like a pen, and the front will face the front. This portion goes on top of the pharynx. So you just insert it like this, and it's very easy. In one swift motion, you go in. That's it. You have a secure airway. Not as secure as a endotracheal tube because the LMA might move, but it serves the purpose. Now he's inserting the air to secure the LMA. And when you have a secure LMA and you're using the ambu bag, you will not hear any sounds coming out of the periphery. So there will be no leakage.
So still we need an ambu bag. Otherwise, can we
You
insert?
need an ambu bag to ventilate the patient. Yes.
That's right. And you wanted to show us the jaw thrust as too.
I will show you the eye gel as well.
Okay. Yes, that was one of my queries.
Yeah, eye gel is much more easier to use. Yeah. This is an advanced version of the LMA.
I see.
I think these are some.
Extraglottic area.
Extraglottic, supraglottic. That means it is outside the trachea, but it seals the airway so that you can ventilate.
And it can be performed by layman as well.
Yes, even the nurses can do it if they have it and have the training to insert it.
Can you narrate, please, Dr. Shamshad?
Yeah. So this is the cup portion, and that's the tube portion, and there's also a port to aspirate gastric content. Okay. these are the things that you can secure the airway with. Afterwards you put it in. Yeah, and these are capnographs. He's applying some lubricants, and they're doing it in a, yeah, you'll see the jaw thrust here as well.
Okay.
Chin lift, right? This is
I'll show you a video of the jaw thrust as well.
the thrust and the chin lift.
See? Just goes in. So see, the tip stays in the esophagus, yeah, and the cuff is located against the trachea. If you have this to secure it, that's okay. Otherwise, you can just use tape or any ribbon to secure the thing, or gauze, bandage like this one.
He's trying this on a live.
Yeah, he's trying this on a live patient, live volunteer.
It's a surrogate trainer.
And this is the capnography. We just attach it on top of it, and we see the waveform in the monitor.
That means it's one type of version of oximetry type.
Okay.
Capnography.
Capnograph actually shows you the amount of carbon dioxide that the lungs are emitting.
Not the oxygen saturation.
Not the oxygen saturation.
In contrast to
that, if the lungs are emitting carbon dioxide, then only you can say that the patient is ventilating well.
Can we purchase this capnography device in Bangladesh?
Yes.
It's available.
It is available.
Fantastic. Like pulse oximetry. It's important to identify the carbon dioxide retention is there or not, right?
Yeah.
আপনার তাড়া নাই তো
না
একটু আমাদের শেষ হয়ে যাওয়ার কথা ছিল Okay, so
so we're looking, I think
I'm just waiting for the original thing him to demonstrate. Yeah.
Thumb over the cheek, right?
Yeah, thumb over the cheek.
Yes.
Yeah, below the earlobes, go to the angle of the jaw. Yeah.
With the index or middle finger.
Yeah. See? You push down on the cheekbones and lift up from the angle of the jaw. Yeah. If you compress it, the jaw will close, but if you're lifting up, the airway will open.
You have to press the cheek, right?
You have to press the cheek so that your hand is stabilized and you lift the jaw up from the angle.
So cheek is depressed, right?
Yeah, cheek is depressed just to stabilize your hands.
Okay.
But you're using your fingers to get the jaw up.
So, is this in addition to head tilt and chin lift, or is it an alternative?
Jaw thrust is usually used in case of patients who have a cervical spine injury.
Right.
But in case of patients who might have a difficult airway, like a short neck or obese patients, we can use both of them together: head tilt, chin lift, and jaw thrust.
Okay. Is it possible, once you mentioned that chin lift without head tilt, is it possible? Because head tilt and chin lift is... To my knowledge,
cervical spine injury, you just do the jaw thrust and lift the chin up. That happens simultaneously. And if the airway is still not open, you slightly manipulate the head tilt until you have a proper airway.
Understood. So
these are the basic
Dr. Shamshad, I think, sorry to interrupt, the head tilt may be risky procedure, right? If there is cervical spine injury.
Yes, head tilt is a very risky procedure. That's why we say don't urge to do head tilts in cervical spine injury.
Yeah.
That's why we use jaw thrust and chin lift.
Jaw thrust.
Mainly lift. Jaw thrust in case of cervical spine injury.
I think we're waiting to see the chin lift, right?
Yep.
Head tilt and chin lift. Can you show us both of those?
Yep.
You can jump to a particular specific point.
Use your left hand on the patient's head, and use the right hand on the patient's chin. Yeah. This is just head tilt and chin lift. Just go back and lift the chin.
Okay. And if we want to try only chin lift, then the left hand we will avoid the left hand.
If you try only chin lift, you'll use the jaw thrust and the chin lift together.
Okay. That's right. Any question from Lutfi?
But here, lastly, I'm confused a little, Dr. Shamshad. Possibly it's my ignorance that if we use the jaw thrust simultaneously, how can we do the chin lift? Both hands are involved, I think, in the jaw thrust, right?
Yes, both hands are involved. In that case, you use your index fingers under the chin just to get it up.
Oh, I see. That's good. Thank you.
So the thumbs will be on the cheek.
Yeah.
The other three fingers at the angle of the jaw, and you index finger. It needs a little bit of practice, which I was taught here while I was in my critical care rotation.
Hands should be with more energy, right?
Yeah. It's not actually about energy. It's more about getting the practice and knowing how to know it easily. Because if
I think now
anything you're using excess force, it's not the proper method.
Will come in round. So I think, may I request Dr. Lutful Kabir to take the floor, please, if you have any query or interaction.
No, I don't have any question.
Everything is okay for you. You're master enough.
Once you have mentioned that agonal breathing, it is not familiar to me actually.
Okay.
Agonal breathing.
Agonal breathing is like, have you ever seen a patient die? They're taking a breath and stopping.
Or strider.
Like a strider. Grunting. Is it grunting just before death? Patient grunting.
Or the gasping breathing.
Gasping or maybe similar.
Agonal gasping and
agonal. By dictionary is meaning pain.
Yeah,
right?
gasping breathing. Gasping breathing is agonal breathing.
Oh, it is same thing.
It's the same thing.
Okay.
Patient is gasping. We are saying that patient is gasping just before death.
That's right.
Okay.
And about adrenaline, that is the 1 in 10,000 addition.
Yeah.
Maybe
10 ml.
No,
1 milligram in 10 mils.
It is the available form.
It is the available form. And we have those in pre-filled syringes.
1,000 is available.
1 in 1,000. But we have to use 1 in 10,000. So we have to dilute with another 10 ml normal saline.
I think we have to add 9 ml, right? 9
9
ml,
ml plus
then it will make 10 ml.
Yes.
Is it okay?
Okay. Yes, 1 milligram in 10 ml, but it is 1 in.
No, 1
1000
milligram in 1 ml ampoule, I think.
No, it is 1 milligram adrenaline in 10 ml should be given.
Yes.
No, 10 ml means it's a diluted form. But before the ampoule is ready with 1 ml containing 1 milligram. So if you pour 9 ml water, it will make actually 10 times dilution and hold
Yes.
together
10,000.
10,000, 1 in 10,000 dilution at that time. Because
Already it is only 1 in
1 ml already there, now 9 make 10 ml.
Okay.
Then how much to push?
Full.
Full. You just
Full.
push it full.
Yeah, we push it full.
Yeah, you push it
So we
full
have
and you
prepared
also give
10
20
ml
mils bonus flush.
Flash, that's right. Okay. So is it effective without any CPR?
No, CPR is the main thing needed. Never stop CPR more than 5 seconds.
Okay.
So may I take some time?
And my
We have
last
still
question is,
question.
what is intraosseous access?
Intraosseous access. This is a very good thing. Yeah, I'd like to show you IO access. We are now all trained for intraosseous access in our skills labs, and also during ALS we do intraosseous access. It is a large bore needle which we drill into the patient's bones, either the head of the humerus or in the below the tibial tuberosity.
Humerus is here.
Yeah.
And the
Yeah.
tuberosity is one good
But
side.
you need
right?
a specialized drill to do the IO access.
Oh, it's this. There.
Specialized drill is needed, right?
Yeah.
Separate needle. Is the drill you mentioned, not the needle.
So it is.
Both. The drill comes in with the needles.
Oh,
The
drill,
needles are different.
drill comes with the needles.
So it is far from our capacity.
No, we can make it available in our hand in the
We-
hospital or emergency setting.
We can't have our ambu bag.
We're the very poor setting country, so we have to accept
Even
it.
National Institute of
Yeah,
Cancer
we
is
should first get the ambu bags.
in the ICU, not in the ward. Only in anesthesia department in the OT, not in a single ward.
So we are trying to develop the acute
Definitely,
medicine nowadays. We are
yes.
hoping many
That's
upward target really.
Look, this is the drill.
Yeah.
These are the needles.
Yeah, what is this? Kilo? What? Sorry? Drill
The
and
yellow thing is the needle.
Needle.
The red
Oh.
thing is the needle.
needle, right?
That's the drill. It is very easy.
Oh.
Once you have that drill,
It will be very easy.
and you have
To
that
drill a person,
procedure
how
performed.
fantastic it is. We're drilling a dying patient.
Because the patient is already dead if you cannot give him fluids. I remember once
I think
we had
incision
a
is not
patient who
important
did
at the
not
dying
have
patient.
venous access
When
back in
you drill
Bangladesh
it, give the IV
while as
access.
an intern.
Not
I
even
think
anesthetic, not even
The
anesthetic.
patient was bleeding out.
Wait, let
Had a venous access.
Yeah,
Does it need any incision?
no.
actually drill it inside the skin and go to the bone. And we are selecting the superficial bone, right? The tuberous.
You are going to inside with that drill actually.
The superficial bone is there, tibial tuberosity or inside the head of the humerus, right?
Just
This is superficial.
This is the drill, and with that needle.
Yeah. That is the needle. This is the drill.
Yes. And the gentle pusher, it is a form, I think. It is.
So we'll attach with the IV fluid, right?
Yes.
And where it will go actually?
The bones?
And the bones
Bones,
inside.
and then the.
No, this
Inside the bone marrow.
vascular, so it will absorb
And
the
it is
fluid.
the central access.
The central access line.
Yeah.
Oh,
And you can also take some bloods to send to the lab, but you have to warn them that this is a
Like
bone marrow sample.
Even bone marrow can be collected from there for study if you need.
I see.
Fantastic.
And then securing an IO channel.
Sorry?
Securing an IO channel.
Yeah, securing an IO channel. As soon as you put it in, it's secured. There is a special dressing that goes on top of it. But as soon as you're able to go in, it is secured. It won't come out.
Yes. And then a channel will be attached with that.
Yeah, a channel is attached, a tube, and you can just start giving fluids, medicines, everything through that.
Oh, is it? So it is practiced since how long ago actually?
You can keep this in for 72 hours once you put it in.
I have heard it earlier, around 10 to 20 years.
20
Yes,
years.
around 15-20 years before also.
Yes. Yeah.
But I didn't view the like this.
That's
that
right.
I was imagining it just pushing the needle through inside the bones. But there's a drill is there.
All right.
needed
So, okay, Shamshad.
there. So I need something really. Sorry, Shamshad, can I take 5 minutes more with you?
No problem.
I was actually calculating the time when to stop the CPR.
Yes.
And mentioned that the cause is not reversible. So at best, we will continue up to 20 minutes.
Yes.
Okay. So if within this 20 minutes, can you give an idea that how many times you are giving adrenaline and or amiodarone?
So we start giving adrenaline within the first, as soon as we identify if the patient has a PEA or a asystole, we
Yes.
give the patient 1 milligram of adrenaline. Or in case of a shockable rhythm, we give adrenaline after the third shock. So
After that third shock, all right.
Yeah, after the third shock. So each cycle is 2 minutes, right?
Yeah, 2 minutes.
So in case of pulseless electrical activity, we give adrenaline after every 3 to 5 minutes. That means after every 2 cycles, means after 4 minutes, we can give 1 milligram of adrenaline. So the patient will get 5 milligrams of adrenaline if the patient is in PEA.
Yeah. But in the shockable one?
In 20 minutes. In the shockable ones, if the patient is in a shockable rhythm, then we don't stop CPR.
But in between, should we give adrenaline in between CPR?
Yes.
No.
After the third shock, we give the first adrenaline in shockable rhythms.
Always
And we again continue after every 2 cycles.
Yes, always after third shock, we are giving adrenaline, right?
In case of shockable rhythms.
Shockable one, understood. But after adrenaline, how many times should we give adrenaline? Then we'll switch to the amiodarone later.
We give adrenaline after the third shock, yeah? And we continue to give adrenaline every 3 to 5 minutes. That means actually after every 2 cycles.
Every 2 cycles.
Yes.
Every 2 cycles of shock or CPR here in the shockable one.
Every
in the
2
shockable, we are
cycles of
not giving
CPR.
CPR.
Every
the
2
shockable
cycles of
one,
CPR.
Sorry, Shamshad, in the shockable arm, we are not giving CPR.
No, definitely. CPR is as well.
We are giving CPR. You never stop CPR.
That's right.
So when the shock will be repeated only one time?
No, shock is repeated every time. You see that the patient is in a shockable rhythm, you give a shock.
Shock, then CPR, then shock, then CPR, right? This.
Yes, shock, then CPR, then shock. After every 2 cycles of CPR, or means after every 2 shocks, after the first 3 shocks, after every 2 shocks, you give adrenaline. And continue CPR, and give shocks, and continue CPR, and give shocks, and adrenaline, and continue CPR, and give shocks, and continue CPR, and give shocks, and adrenaline.
So how many times should we give adrenaline, then switch to amiodarone later? Suppose shock CPR adrenaline, shock CPR adrenaline, how many times like this?
You continue to give adrenaline throughout your CPR attempt.
Okay, then when we switch to amiodarone.
Amiodarone is after 3 defibrillation attempts. You give the first 300 milligram of amiodarone. Yeah.
After 3 defibrillation, that means 3 shock.
The
first time you're giving adrenaline, it is the same time you give amiodarone.
Sorry, can you clear again, please?
For a shockable rhythm,
yeah,
you are giving adrenaline after 3 shocks.
Yes.
At the same time, you're also giving 300 milligrams of amiodarone.
Both together?
Yes.
Oh, right. It was not clear really before. I think is a modification.
After two more defibrillation attempts, that means 2 more cycles, you can give a further 150 milligrams of amiodarone if you think the patient will benefit from it.
Oh. Maybe it was not clear to us that the adrenaline immediately followed by amiodarone. We are thinking that adrenaline given 2 or 3 times, then we are switching to another drug.
If amiodarone is continued or unavailable, then lidocaine in a
Yes.
Yes.
You mentioned that the atropine is not working at all, but I think we can find in the Davidson book, it is mentioned that atropine, I think, is written there. Do you like to that?
The new algorithm, if you open Davidson and go to the new algorithm, you would not find atropine there. Atropine is only used in case of bradyarrhythmia, not in cardiac arrest.
Oh, I see, maybe.
It was written in the ACLS also.
Before.
That's right. But it is
Before.
maybe...
Currently, really, I'm sorry, I didn't go through the very, very latest one in the meantime.
Yeah.
Thank you.
So,
Any more?
Shamshad, thanks again for your very informative presentation. And we have a guest. Actually, we have a guest that is for the website development.
So we have to give attention to him.
That's right. And okay, just put.
No, just I think 1 minute more. You uttered the word somewhere, asynchronous resuscitation or like this something.
Yes.
Right.
So,
Just can you make it clear? In which slide can you open it, please?
Yeah.
Asynchronous.
I'll go to the slide, no problem. Synchronous resuscitation is when you are giving 30 compressions and 2 breaths.
Yes.
Yeah, that is synchronous resuscitation. You give 30 compressions and 2 breaths. But when you already have an airway in place, like an igel or an endotracheal tube, then you do not need to give synchronized 30:2. You can continue with chest compressions. To minimize chest compressions, you just continue with chest compressions and you give breaths in the physiological rate, like 16 breaths per minute. It does not have to be synchronized with the CPR.
Oh, that means it will be very more physiologic when we say that this is asynchronous resuscitation, right?
Yes. But you need to have an airway in place.
Yes, airway. After airway. So Shamshad, I think I'm very happy, and as much as I gathered is enough for me today. Dr. Kabir is talking less really today. I think he understood much of you, and we are very happy having you here really. Do you have any summary words for us for a few seconds, please? So we are actually 3 together, myself, Dr. M. Osman Ghani, and Dr. Lutful Kabir and Dr. Zubair with us, with some other guests also, and junior doctor is here also as well, Dr. Nasim. So can you have some few summary words for us, like take home message, please?
Take home message is we need good quality CPR. So everyone should be first trained for basic life support. That is how to do the chest compressions and everything. All the places should have an ambu bag. And certain people should be trained in ALS. There are a few other things that we need to focus while delivering advanced life support is actually the team management. Because there needs to be a team leader who does not touch the patient, is not involved in providing direct care to the patient, but is overseeing all the other work.
Exactly.
The team leader's responsibility is utmost because he has to stand away and observe everything, take everything in, what is going on, what needs to be done, and what we should check for. Have we gone through the H's and T's? That can be discussed maybe in another session, hopefully. So high quality CPR is very important. Knowing the ALS algorithm, getting some training for the advanced airway and the basic airway management. All of this will lead to a better patient outcome. And another very important thing is to select candidates who are going to be good for CPR. Like while I was back in Bangladesh, we used to perform CPR in patients who had advanced cardiac failure, who had an ejection fraction of less than 20%, many comorbidities together. These patients actually would not benefit from the CPR, but we still had to do it from a social point of view because
Right.
the patients' attendants wanted it. But we should actually start to educate patients and their attendants to have advanced directives that do they want CPR or not. In
Yes.
UK, mostly DNA CPR decisions are made by physicians. I can
Oh,
say that I won't do CPR on this patient. But maybe in Bangladesh, if we take the patient, we give the power to the patients and explain everything to them clearly, then maybe the very aged patients and also their relatives will understand that the CPR would not benefit the patient and make an advanced directive and take out the hassle of providing unnecessary CPR and unnecessary trauma to a patient who's actually dying and let them die with dignity.
we understood. Okay, can we conclude now? Dr. Shamshad, see you again.
Yeah.
And what will be our plan really for the next session?
We'll make a plan together, inshallah. We'll have another good session in the future. Thank you all for attending. It was very lovely speaking with you guys, being with you in some sort of a way, even if not physically, electronically. It was very nice today for me.
The life is becoming electronic more than the hard part nowadays. We are the virtual life. Everything being shared by the virtuality. So thank you, Dr. Shamshad, again, and we like to
Thank you.
sit with maybe with Dr. Anar also again to arrange a bigger one. This is a very good trial, really, and I think we are happy today that we made
And
a very
maybe in the bigger one, we can again hold the ALS session because I think this is important.
Actually, we had the record of you in two parts though, as we are
Yeah.
interrupted in between. So I don't know what is the Dr. Zubair's plan. I think easily it will be given, be uploaded in our group. Maybe those who want to see, they
You
can
can
view it.
easily edit it and combine it in a one file, no
Yeah,
problem.
we understood to make one software is there. Even then we can give together immediately in the raw matter is better. It will be very lively really without any addition, right?
Yeah,
So I think you have this permission for us, is not it?
no problem. Thank you so much.
Okay, see you again and talk to you again. Allah Hafiz.
Allah Hafiz. Assalamu alaikum.